Hey, hello everyone. Thank you for joining us on this webinar, Price Transparency and No Surprises Act Compliance. My name is Cassidy Avila, and I'm the Program Coordinator for the Texas A&M Health Rural Engagement Program. We are recording this webinar, and we will share a copy of the recording with you in a follow-up email, as well as the slides if you'll give us about 48 hours to get that posted. Following the presentation, we will also have time for Q&A today, so feel free to drop your questions into the chat box. You can drop them into the group and we'll address them at the appropriate time, or you can send them to me and I'll make sure that we address them at the end. I would now like to take a moment to introduce our speaker, Rachel Pulian. Rachel is a seasoned healthcare consultant with over 25 years of experience, specializing in revenue cycle optimization and regulatory compliance. Her expertise lies in the mid-cycle of the revenue cycle, including revenue integrity, chargemaster maintenance, charge capture, and coding. Rachel partners closely with clients to assess the health of their revenue cycle operations at Eide Bailly and develops tailored process improvement strategies and ensures accurate code and charge assignment. She also provides compliance program assessments, risk analysis, and project management support for system implementations. So Rachel, thank you for being with us today, and I will go ahead and hand it over to you.
Thank you, Cassidy. And thanks everyone for joining us this afternoon. I won't spend a whole lot of time reintroducing myself since Cassidy gave such a nice introduction there. But you might be wondering what someone that really works mostly in the mid-cycle of the revenue cycle has to do with Price Transparency and No Surprises Act. And it will become apparent as we go through this presentation, but price transparency actually impacts quite a bit of the work that we do in the mid-cycle, especially when it comes to the chargemaster, and we'll tie that in a little bit during this presentation. And the No Surprises Act is just something that comes up as part of a lot of the compliance work that I do in general at organizations. And so we'll touch a little bit on that act as well during the course of this session. And with that, I'll get started because I know that the time will probably go by pretty quickly. So I want to make sure that we have time to touch on all of these various pieces. So we'll go through the price transparency rule and the latest updates for 2025, which as of May 22nd, that is the most current update for price transparency. And then we'll evaluate how pricing and the chargemaster are connected to the price transparency rule and some ways to manage those chargemaster updates. And then we'll share the No Surprises Act compliance components as well and go through those pieces. So right away, just kicking it off with the price transparency rule, I have a little bit of history outlined here, but we definitely don't need to go into detail going all the way back to 2014, 2015. But basically, all of this started with the Accountable Care Act. And then we move into the inpatient final rule as part of the ACA in 2015. Then there were some additional updates to the inpatient final rule several years later in 2019, and that's when they really started expanding on the price transparency regulatory pieces. So this is when we now started hearing about the machine readable file, how it needed to be updated annually. What we didn't have was necessarily a lot of parameters or guidance around what some of these components needed to look like. As I've noted here, the machine readable file format basically at that time said it can't be a PDF file. But now we know going forward that that has changed quite a bit in the more updated renditions of the price transparency rule. So for example, as we get into 2019 a little bit further, now there is some penalties associated with the price transparency rule. There's an executive order that's issued that's regulating or requiring hospitals to post their charge information. That included not only the charges, but negotiated rates. Shoppable items and services became a part of that executive order in 2019. And in addition to what you see on the screen here, the Office of National Coordinator of Health Information Technology, it's called the ONC, discussed the interoperability of the EMR, and that's where we started seeing the wording around negotiated rates and what that might mean for pricing transparency. So in that executive order, as I mentioned, that's when it starts referring back to that ACA. It's building upon all of that pre-work that was then issued there in 2014 and 2015. And then in 2020, the outpatient PPS proposed and final rule That then created that avenue for the rule setting process around price transparency. And then in 2021, it became a requirement that this machine readable file needed to be posted on our websites. And the other piece of that is, and I'll just forward here really quick, and I might go back here in a second, but then also the shoppable services piece. So that's in 2021, where we really had to make sure that we were in compliance with these two components. So, under the hospital price transparency regulations at this time, the hospital had to make public its standard charges for all items and services that it provides in that comprehensive machine readable file, among other requirements. But the hospitals had historically been given discretion on how they chose to display those charges. And now in 2021, that changed. And there's some additional updates that I'll discuss here in a moment as well. Oh, sorry, I didn't mean to advance quite yet. Um, so then, like I said, in 2021, each hospital in the United States was required to make this information available. They had two ways that they could do this: the comprehensive machine readable file with all the standard charges for items and services, and with the shoppable services file and a price estimation tool. So that's where we really started to see, like I said, some more structure, guidance, some very tangible aspects of the price transparency rule that we needed to abide by. So, as a display of the standard charges, it needed to include the 300 shoppable services in a consumer-friendly format, and as well as a price estimation tool that would be a component on the website as well. Note that these items would need to be updated at least on an annual basis. So it would require us to go back in and touch and look and make sure that these are current each year. So getting a little bit into the more current world for price transparency, in 2024, we saw some new hospital price transparency components. They felt like compliance was lagging in the industry. And there was a report from the Patient Rights Advocate Organization where they found that only 36% of 2,000 hospitals that they reviewed fully complied with the 2023 price transparency rules. So this kind of kicked off a little bit more scrutiny around price transparency. And as noted previously, hospitals historically had that discretion to choose how they displayed their standard charges. But in the final rule, that sought to increase that standardization. It required hospitals to now display their charge information by conforming to a CMS template and a CMS layout. CMS, I went ahead and started identifying non-compliant hospitals by evaluating their websites and looking for that public information. And they were just basically conducting those audits on an internal basis. And non-compliant hospitals then began receiving warning notices instructing them that they had, for example, 90 days to comply with the CMS price transparency rules and update that information. And if not, then they were subjected to civil monetary penalties. And there was a penalty structure that was associated with that based on the size of your hospital. And so this just really also highlighted to the rising healthcare costs that have been affecting consumers and the increase and really pushing forward that increased price transparency from hospitals so that the patients could be more selective and more cost effective in the services that they were choosing to have performed. So here just gives a little bit of a timeline of 2024 into 2025, since this was a pretty active time frame for price transparency. So as of January 1st of 2024, so about a year and a half ago, the website display requirements went live, and that included placing a text file with a direct link to the machine readable file. You also had to place a footer link to your price transparency information on the homepage of your hospital website. And then CMS, in doing so, believed that these requirements would improve the automated accessibility of the hospital's standard information and streamline the CMS enforcement of the requirements. So that was really kind of the why behind some of that. And then as of January 1st of 2025, the data elements that CMS had put in place, they acknowledged that it was probably going to take a little bit more time for providers to comply with that and prepare for some of the upcoming regulatory changes that they were expecting to see, such as estimated allowed amounts and detailed drug information. So that was all new as of the beginning of 2025. So just reiterating that a little bit, this is the information around the standardized format that started in 2024. The templates offered from CMS were either a CSV file or a JSON file. JSON we found was not extremely popular. That's a little bit more labor intensive to maintain and utilize. So in most cases, at least what we've seen here at Eide Bailly with the work that we do is most organizations are using the CSV file. And then also CMS stated in their outpatient final rule that the machine readable file was not meant for necessarily patient use, but it was to drive competition in the healthcare industry. So I'm not sure if that's come to fruition in the way that they anticipated, but that was the intent around some of this information that they were putting out to the hospitals. And then here in this next slide here, I just wanted to share a link to the file format information around the price transparency machine readable file. So that link is there, and that information that you can find on the website, specifically this webinar, and it's still up as of today because I've been checking just to see if everything that we have on the website is still current. This link is still up, so if you need a refresher on what the file template is or what it should look like, this webinar is still there for viewing. And this is just showing a little bit more about the CSV wide format example. This is probably all pretty familiar to everyone on the call at this point because you've all been dealing with price transparency now for a number of years, especially when these templates became mandatory and you started working with them a little bit closer and more frequently starting in 2021. And just of note too, that the majority of the machine readable files that have been published thus far typically are that CSV tall template. However, you do have the option to use some of the other templates that are noted out on the CMS website. This is a little bit about how the enforcement component rolled out in 2024. And I know I mentioned that in a previous slide around the acknowledgement letters, typically 90 days to comply. CMS may require payer contract information from the hospital to assess compliance. So there's a couple of different things that CMS can do and might do in order to assess compliance for the price transparency piece. So now I want to get into the 2025 executive order and the subsequent guidance that has been published since May 20 or as of May 22nd. So on February 25th, there was an executive order that was building upon the previous administration's executive order, that one that I mentioned from 2024, around price transparency. And the executive order references fulfilling the promise of radical transparency. So specifically, it's directing the Secretary of the Treasury and some other organizations, Health and Human Services, for example, to take all necessary and appropriate actions to implement and enforce compliance with price transparency. So it includes actions to occur within 90 days of the date of the executive order, which brings us to the end of May. So if you've been paying attention to the timing of this executive order, we pretty much anticipated that we would get additional guidance at the end of May, which we did. So rather than keeping everyone in suspense, I'll just get to the meat of that May 22nd price transparency guidance. So in a nutshell, the guidance indicates that hospitals must encode a standard charge dollar amount in the machine readable file if it can be calculated. And I have that portion highlighted first because that's what we're going to talk about on this slide initially. So what this means is that hospitals that can derive a dollar amount from a hospital's payer-specific negotiated charge must encode that value in that payer-specific negotiated charge dollar amount data element that's within the machine readable file. So breaking this down a little bit, if you have that data element in your machine readable file, You might have a payer-specific negotiated rate for an Aetna plan, for Blue Cross, for United Healthcare, and some others. And the way that the file is structured, you can list that rate for each one of those plans. And that's what CMS is expecting to be seen, or what they're expecting to see now in the machine readable file. So basically, CMS no longer wants these fields to contain estimate amounts. They want actual dollar amounts that are associated with these contracted rates. So there is one section here I mentioned too, that there may be situations where the payer-specific negotiated charge is like maybe a percentage of a fee schedule, and that information may not be available to the organization. So in these instances, a hospital can indicate that the payer-specific negotiated charge is a percentage and provide that additional information in the type of fee schedule in the document. So at least that way you can note that in the machine readable file. So that is allowed. So the second part of the May 22nd guidance is that hospitals should discontinue encoding 999, there's 9 nines, in the estimate allowed amount data element. So again, this is effective as of May 22nd. So this relates to services that could have variable prices. And I'm just going to use a knee surgery example. So, or any orthopedic procedure for that matter. So some organizations may charge their surgeries based on time. And that time may fluctuate based on the patient. And so there might not be a charge that is consistent for every single orthopedic surgery that takes place at the organization. But because of the overuse of this option within the machine readable file, CMS is now instructing that an actual dollar amount must be entered. And I will say that this may not affect smaller hospitals, such as those of you that may be on this call, because you might not see this type of variability in the services that you offer. But this is for your awareness in case you have been utilizing this. This is something that would be discontinued as of May 22nd. So really what hospitals are expected to do is that they should be going back to their remittance advices and using that data to determine the dollar amount associated with these types of procedures. CMS feels that there are infrequent scenarios where a hospital has limited historical claim information. However, I will say, and I have a link for this in the presentation, when you go to the May 22nd guidance, it does give you 3 different scenarios that you might encounter on how you would input this information from your remittance advices. So if you have 12 months worth of data, if you have less than 12 months, if you have partial information, it gives you some examples of what you do in each one of those scenarios. I'm not going into that level of detail in this presentation, but that is available. And again, I have a link that I'll show you here in a moment. But basically, when CMS conducted their analysis, they found that 63% of the files that they reviewed had these values, and that there were 38% of those that had more than 90% of their files contain these values. They did sample larger acute care hospitals. So again, I would just encourage you to go back and look at your files and see, do you have these values noted in your file? And if so, you would want to convert those to an actual dollar amount by using your remittance advice data. So I won't spend a whole lot of time on the data elements. It gets really technical when we get into these pieces. And if some of you have maybe worked with a vendor or someone that is covering this for you or ensuring that these data elements are satisfied, then you really are entrusting them to make sure that these components are there. But for your awareness, I did want to include this information in case you are keeping up with this on your own and are working with these files intimately on an annual basis. This just gives you that information around the payer-specific information and those charges that need to be now updated based on the May 22nd guidance. The coding information that is included in these files. Of course, we want to make sure that we have the most up-to-date code sets that we're including in the file and in the information as well. And then also the descriptions. One of the things that came out in July in the proposed rule was that the files needed to contain a description of the actual service as well. So that is just something that you want to make sure you really check the box on all of the components and the data elements that are required within the price transparency rules. Again, I note here that starting in January 1st, the drugs and the type of measurement are now included in this. So I would, if you're using a vendor to help you stay in compliance with the CMS rules and regulations around price transparency, I would definitely go back to them and just ensure that they're up to date with the May 22nd guidance and that they are keeping track of those changes going forward and making changes to your files. One thing that might clue you into that is if they're requesting information from you, because I would imagine that they're going to need data that only you can provide in order for them to update your files accurately. And you'll want to make sure that that is being performed and is being performed accurately for your organization. So here's a couple of resources. So this is going to bring you directly to the main page for price transparency. And one of the first things you're going to see on that page is the updated guidance that we've been talking about. If you click on this link, it will bring you to a 4-page document that outlines the May 22nd guidance. It gives you those scenarios that I talked about regarding the 999 field that you would want to take a look at, and just further clarifies and dives a little bit deeper into what the expectations are as of May 22nd. One thing I also wanted to show you too are some pages to bookmark. These are just some things that you can get off of that same page that I listed here in the very first link. So once you click on that, you'll see this, and then you'll also see these links as well. So these are just some good pages to bookmark and make sure that you have them easily and readily available for yourselves. Within the page, I just took a couple of screenshots here. So they do give you in this repository, this is that main page, and this GitHub is a computer code term. I'm not very familiar with it. That's a little bit outside of my wheelhouse to get into the nitty-gritty with some of these things. But this is where we find out this is the requirements for the page and for the machine readable file. This is not an all-inclusive list that I have here, but this gives you various scenarios, and then it references file formats that could be utilized and applicable for these various scenarios. There's probably double or triple this on the actual page, but I just wanted to give you a screenshot of what we see here. The other link that I wanted to share here is the tools page, and there's a number of links off of this tool page that are beneficial. You'll want to bookmark this one as well. And then they also have the ability to upload your machine readable file and see if that format is in compliance and if there's any issues at all with the file. So this is just a screenshot of validation results, errors that might be found, just as an example. So I just wanted to share that with you. So if this is some work that you're doing on your own, these are some tools and some resources that you can utilize to help guide you through this. So this is what you would want to see when you upload your file for compliance. There are 2 warnings on this page that relate to the drug posting, but that's related to that new guidance as of January 1st. And then this also helps you with naming the file and meeting the requirements from a naming perspective. And then this tool allows the facility to create compliance text files. So it has a link to the FAQs around the text file requirements, and it provides a couple of examples and scenarios for you to take a look at there as well. So a lot of information around price transparency. They've really built out that price transparency landing page, and there's links to a number of different things and multiple resources to help you with compliance. Not that it makes it easy, but at least we know we have a page that we can go to. So what you should do is review your current website posting, assess if you need to make any adjustments based on the, what CMS has noted. allow your allow yourself to make those necessary corrections. We say allow time, even though we're really kind of past time at this point because of the May 22nd guidance that was just issued. You'll want to see have those updates been made, and are you in compliance as of May 22nd? So those are some things you'll want to make sure you do right away. And then, just some final thoughts. Understand your price transparency requirements. In addition to the federal side, does your state require anything? You will want to make sure that you have an understanding of any state requirements as well. And speaking for Texas, I don't know that they do, and that's something that I can certainly look into if anyone has any questions on that. And then establish a plan and governance structure for price transparency and be engaged in that process, even if you have a vendor that's covering that for you. And then just demonstrate those active efforts towards compliance. We know that it may not happen overnight, but if you're making active efforts to be in compliance and working towards that, that does go a long way. And establish some policies around your pricing, defensible pricing, how you set your charges. And we'll get into that a little bit more here in a moment, but that also assists in the overall compliance picture around price transparency. And then continue to create those consumer friendly educational options for patients to ask questions. All of that is strongly encouraged as well. So I'm not going to get into a whole lot with the chargemaster, but we know that the chargemaster and price transparency ultimately affect one another. So when we make changes to our chargemaster, particularly the price, that's going to impact our price transparency file. And so we know that we've got some basic components of the chargemaster. We need to understand, when is our chargemaster updated? When do we conduct pricing increases, and how is that process laid out and established at the organization so that we can tie that back to our price transparency file as well. So successful chargemaster maintenance is going to include a team. It's going to include the clinical leaders, coding, revenue integrity, billing, as well as finance. And of course, there's good reason for all of this because we know that finance is probably going to have their eyes on the price transparency components as well as budgeting, productivity, all sorts of things that have to do with the departments. And the chargemaster drives a lot of that information. And that's not even speaking to the revenue side of things. The revenue side, of course, is driven by the chargemaster and the charge capture components that take place within the organization. I've listed some tools that can assist with the chargemaster maintenance process. And just to share a few best practices around the chargemaster, to have a defined process for facilitating requests to make changes and updates to the chargemaster, have an approval process in place as well. We don't want changes to be made that don't go through that proper approval so that we know that we've got the correct code, the correct revenue code, the correct description, and ultimately the correct price as well. And then who's involved in those pricing discussions and what goes into the setting of the price. It should be a collaborative effort to determine what resources are being utilized at the organization, the personnel, the equipment, the time it takes to do the procedure or supply the service. So there's a lot of factors that go into the pricing discussion. And then even in addition to that, what do we need to have in the documentation to support the charge that we're going to be capturing? Who is going to capture that charge? Who's responsible for that? And then are we taking into consideration the billing and the payer nuances around this? It might be great and wonderful to add a new service to our organization and provide that to the community, but we need to know the financial impacts of that if we don't have any payers that pay for the service, for example. So that's just some considerations there around the chargemaster. I do mention revenue integrity. Just briefly, this is a component to just ensure that we are identifying those causes for revenue leakage, that we are compliant with our charge capture documentation and the performance of the work that's being provided to the individuals at the organization. And I'm listing some core revenue integrity functions. The chargemaster is one of those core functions. Sometimes revenue integrity is also responsible for pricing. So you do want to understand that responsibility and that component within your organization so that you can ensure that price transparency is considered at the same time. So some best practices around the chargemaster: review your policies and procedures, implement a good process that includes a team of clinicians, chargemaster experts, revenue integrity, coding, billing, reimbursement, and finance. Provide education to those revenue producing departments so they understand their role and expectations around charge capture. I highly recommend conducting an annual internal charge master review just to keep up with any changes that might be ongoing, but then have an external charge master review that's more comprehensive, includes the clinical departments, and conduct that every 3 to 5 years. And I would perform regular charge capture reviews just on an internal basis. And I say monthly in this slide. That's to that's for the purpose of maybe taking a department, for example, and just looking at a couple of accounts for that one department and look at the claim from top to bottom to see if we captured all the charges. Is the documentation there? Is everything accurate? We will touch on pricing here too, because the pricing, of course, is going to relate to price transparency and also defensible pricing. So it's one thing to have all of that information out for the price transparency compliance, but we also need to know, well, how did we arrive at these prices in the first place? Some of it may be very self-explanatory, like the examples that we talked about earlier when it comes to the negotiated rates for your health plans, or for the remittance advice data that you've received back and you've established those prices based on that information. But also we have other charges that might fall outside of that. So we want to include in our policy what our pricing strategy is, what are the markups that we have in place, do we have annual price changes, do we have interim price changes, how do we establish prices for our new services that we implement at the organization. These are just some things that you'd want to include in your pricing policy to show that information around the pricing transparency, pricing strategy component. So the goal here is not only to have it is to have a defensible and having that policy in place. It also speaks to the market and taking that factor into consideration as well, and how that might speak a little bit more about the various components of your pricing strategy. So some other things to consider here is engaging with your clinical departments on strategy, because they might know some things about the market and about some of the services that are being performed in the organization or in the community. So, for example, I've been and visited at organizations where we talk through radiology prices, or maybe we talk through therapy prices. And there's a strategy around the pricing for those particular departments. If, say, there is a standalone radiology or imaging center in town or just up the road, or if there's an independent therapy group that's operating in the community. So those are some things that have to be considered when it comes to the pricing component as well. And we often find that an across the board price increase may not necessarily be in the best interests of the organization because of some of these sensitive or strategic departments that you're focusing on. And then there's the sensitive items too. So the things that you might get patient complaints about. This is a good time to visit with your customer service department and see, well, what kind of calls are we getting? What kinds of things are patients picking up on that seem to bother them or get them a little riled up? So that those might be things that we want to be a little bit more cost conscious about. And that even can trigger some bundling or package pricing options that the organization may want to look at as well, especially when it comes to low cost supplies, low cost over the counter type medications, and those types of things. So another thing to look at is your cost to charge ratios, of course, your reimbursement. So any type of charges that are based on a percentage of charge and how those adjustments might make a difference. Charges really do matter. And I think we know that, especially in our small communities. And if you're a critical access hospital, it definitely plays a big role in the reimbursement for the organization. There's going to be maybe some limitations on price increases that you'll face just based on your payer contracts. That's also where having a pricing strategy and understanding where that net increase falls for the organization and doing that math and that analysis so that maybe you raise prices in one department, maybe you're flat in another department, and maybe you even decrease prices somewhere else because of a strategy or a sensitivity issue. And then you come out at the net rate of being under that overall price increase that your contract has indicated for you. So there's some analysis that needs to go into some of this work as well. There's the budgeting process, of course, that plays a role in some of the increases versus decreases. And again, this is a team approach. Engage with your chargemaster team, the coders, the clinical personnel, and understand the impact from a revenue and budgeting perspective that these potential adjustments might make to the organization. So questions to consider here at the end of this portion. Does your organization have a current and updated pricing and chargemaster policy? Do you feel that you have a defensible pricing strategy, and are you set up for success? So those are some things just to go back to your organization. And again, tying that back into the price transparency component, especially in light of the new guidance that came out on May 22nd. So now we're going to dive into the No Surprises Act. And again, just a little bit of background, and we won't spend a lot of time on this, but what is a surprise bill? Well, that's when we have a provider or facility providing care to a patient that is in a non-participating or out-of-network provider with respect to their coverage, and the individual is not aware of this. This can happen in an emergency and in a non-emergency care setting. The out-of-network provider facility impact to this is that balance bill piece and the ability to be able to balance bill the patient once that claim has been processed to the payer. So that's where a lot of this stemmed from is that balance bill then that the patient received. So they found that there was a need for regulatory action based on some statistics. 2/3 of adults worry about being able to afford their medical bills. 41% of adults with health insurance received a surprise medical bill in the previous 2 years that this study was conducted. There was a Vox project that reported accident victims receiving care that were out of network hospitals and receiving bills over $20,000. And then in February, several years ago, 33 states had some surprise billing laws, but the federal government found that this was not enough protection in some cases. So that's really where some of this stemmed from. And they analyzed claim data, which of course drove to the most common situations for when a surprise bill might be generated. So in that assessment for need for regulatory action, they found that 18% of emergency department visits on average resulted in a surprise bill, which is probably definitely higher than what we'd want to see. And it was often associated with different physician specialties that might be working within the organization. So, I think about if we have, there's coverage from an emergency medicine perspective, or we send that EKG out to a cardiology group that then reads that EKG and they happen to be out of network. And so that professional charge then impacts the patient bill. If they receive a procedure or a surgery of some kind and the anesthesiologist is out of network, maybe the radiologist that's reading the X-ray exams. So these are just some examples of where this can come into play and where they found that this might happen during the course of their analysis. So providers generally remain out of network, and they do so because it does not affect their volume. And historically, balanced billing was used to leverage negotiations when looking to join health plans or networks to obtain some higher network payments. So there was some if you will, valid reasoning perhaps behind why some of this was happening, but it was to the detriment of the patient. So furthermore, there was 75% of air ambulance transports were out of network, which is probably not surprising, given that air ambulance is certainly not something that we're going to be utilized often in in many cases, or especially in some of our more remote locations, most definitely they would be out of network. And then out of network cost sharing and surprise bills usually did not count towards an individual's deductible or their out of pocket. So they were still paying those bills, and it wasn't driving down their deductible. So that was another cause for concern there. So I did want to include here the CMS landing page for the No Surprises Act has not changed much since this was implemented. So this looks virtually pretty much the same. So this is the first thing you'll see. And of course, there's multiple links that you can go into from the landing page. But then you can also look at the resources within the landing page, and we won't go into all of these, but if you're looking at policies and resources that you should have at the organization, posting information that should be shared with your patients, this is going to be located here. The revolving out of network payment disputes. So there's a payment dispute process that can take place, and it's outlined pretty extensively here on the landing page or through these links rather. And then consumer and consumer advocates. So there is information for the patients on this page as well. So it's probably a good idea to know or just be aware of this, because this is something that patients have the ability to access and take a look at and understand for their own knowledge as well. So there's a couple of components to the act. And so we'll talk about part one, which is who is protected under the No Surprises Act. And that is going to be the patients, the beneficiaries, the participants, those that are enrolled in a group health plan. They might be in a group or individual health insurance plan. It might be a self-funded plan that's offered through their employer, or it might be through a federal, state, local, or multi-employer plan through various marketplaces. So even though a patient may be a member of a health plan, that doesn't necessarily mean that they're not going to receive a surprise bill. So that's who's covered here under the No Surprises Act. The Medicare, Medicaid, other governmental payers, they are excluded from the No Surprises Act. So the applicable settings when it comes to the No Surprises Act is going to be hospital and freestanding emergency care services, with the exception of post-stabilization care, non-emergency services from non-participating providers at participating facilities. This can get very confusing when we think about this piece of it. Air ambulance that we already covered. And then non-emergent care, such as ancillary services, some of those professional services that we talked about from surgeons, anesthesiologists, pathologists. Also, if there is no in-network provider and an unforeseen urgent medical care or unforeseen urgent care is provided, that is an applicable setting for the act as well. So by definition, what is a healthcare facility under the No Surprises Act? It's a hospital outpatient department, it's a critical access hospital, and it's an ambulatory surgery center. So that is how a healthcare facility is defined under the No Surprises Act. So part of the part one requirements is there must be public posting and public disclosure of the No Surprises Act and the commitment of the organization to not surprise bill. It must be posted in a prominent place. So oftentimes the emergency department is a very common location for the posting. Your registration areas throughout the organization, those areas that can be directly accessed. So let's say if patients go directly to lab or they go directly to radiology for any type of service, physical therapy, those areas. So you'd also want to make sure that you have information available in multiple locations at the organization. The patient should also receive a one-time notice. It should be a one-page or can be a one-page notification in a manner selected by the individual. So it could be information for the CMS website. It could be a pamphlet. It could be something that's handed to them, emailed to them. It should be issued no later than the date and time from when you are requesting payment. So if there is any kind of a payment that's requested up front, like a co-payment or a co-insurance, this information would need to be shared at that time. If no payment is requested up front, then this should be supplied to the patient no later than the date the claim is submitted for payment to the plan. So at the same time that that claim is sent to the payer, the patient should also receive a No Surprises Act notification. And it should be provided in a manner selected by the individual. So like I said, in person, mail, email, electronic, paper, any method that the patient prefers is the way that they should receive the information. So one thing not to not forget about this is the physician agreement considerations, which we kind of touched on a little bit in talking about the other providers that might be providing services within the hospital walls. So scheduled items and services and the policy that should surround this is really related to the balance bill. So if your policy is to balance bill, then these are the requirements that need to be in place. Some organizations don't balance bill. So this is something that you would want to make sure that you have a conversation with your business office and your finance leaders to determine, is this a practice of ours? And if not, then really this piece and component of the act will not apply to you. But if you do balance bill, then this is the information and the requirements that are in place for those scenarios. This is the version of the consent to waive. Nothing's really changed with most of this information. The estimate that has to be provided to the patient, this also needs to be in place. And then an agreement to pay for out-of-network care potentially. So this is something that all needs to be covered and discussed with the patient at that time, at the very beginning of their care, if you're asking for any kind of co-payment, or like I said, when that claim is generated. So then the part two of the No Surprises Act is related to protections, and who does this apply to? So the part two is uninsured and self-paying, short-term duration insurance, health sharing ministries, workers' comp, and when is it required? It's upon their request in the case of self-paying and at the time of scheduling. So a lot of times you tie a lot of these pieces in with the financial assistance policy that might come into this conversation. We won't get into the details of the financial assistance policy, but this is something that oftentimes is brought to light at the same time because we're talking about the good faith estimate. And finances will be a part of that conversation just organically. So this generally applies to all providers acting within the scope of practice of license or certification. So physicians, other healthcare providers, and it includes air ambulance. It applies to all facilities and institutions licensed as such. To the extent scheduled at least 3 days in advance, we would want the patient to get that good faith estimate. So that's really how that comes into the picture. With this is understanding what is your process to give that patient that estimate, and do we have that process nailed down, and is it in place at the organization to be consistent with that good faith estimate, how we arrive at it, what is our process. And a lot of times that then generally just kind of leads into some of those financial assistance policy or payment discount conversations that might be taking place. So again, there's public disclosure, just the same with the part one, posting in a prominent place, must be provided to those covered under this provision, scheduling items or services or request an estimate. So that's where this comes into account here. So again, the CMS website, you can provide this on paper or electronically. If the patient has no internet access, these can be provided on paper, in person, or via mail. We recommend a disclaimer is included on the good faith estimate discussing the provisions of the item or service, that complications can occur that may change the charges. You may issue a single good faith estimate for recurring services not to exceed a 12-month period of time. This is information to share even if there's zero financial responsibility and even if there's a set price for the service. So again, for the timing of this, if the patient has a scheduled service, best case is to provide this information 3 days before the service is being provided or within 1 business day of scheduling. So in some cases, you might have a patient that's going to be seen within 2 days. Well, we would want to get that to them as quickly as possible. And then for those requests not scheduled at least 3 days after that requested estimate or the time of the original request. A lot of information here, but the good faith estimate does need to be clear and understandable language to the patient, understanding that many of the patients aren't necessarily going to have the backgrounds that we have when it comes to the healthcare industry. And so we want that the language to be in that conversational or, everyday type language. We need to include the date of birth for the patient, expected charges for the items and services, include any items or services reasonably expected to be provided, and include any items or services reasonably expected to be provided by another healthcare provider. So that I think a good example of this would be a surgical case, and you know that an anesthesiologist might be providing some services. That provider may be out of network. So that would be an example there. And that may not be the case for some of your organizations. You might have CRNAs on staff that you really don't run into some of these issues, but that's just one example that came to mind. What also needs to be included is the expected charges must be provided within 1 business day after receiving the request and must inform of any charges that change from the originally scheduled procedure. So I know that there are times that a patient goes in we'll just use the OR as an example, goes into the OR with one expectation and something else is found. And now that changed the procedure. So we want to make sure that we inform the patients as quickly as possible about those changes. Include any expected billing and diagnostic codes that would be applicable. And then here I do have a bullet point related to the financial assistance policy and the requirements under 501R. And there are some very specific components that need to be included in your financial assistance policy. And oftentimes we see this connected with and correlated with good faith estimate procedures and processes. So that's why I do mention it here. But just for awareness, there are some compliance components that need to exist within your financial assistance policy. And then there's the advanced explanation of benefits component to this as well. There is a dispute resolution process that can get very technical, and I know of, in fact, he's an attorney in Dallas, I believe, that I've worked with in the past, that this is pretty much what his practice performs, is dispute resolution when it comes to the No Surprises Act components and the good faith estimate. And it's a very, like I said, technical process. And I will not pretend to understand all of the legal aspects around it, but I did want to mention that there is this patient-provider dispute resolution process that's outlined on that landing page that I shared a couple of slides ago. It applies to the good faith estimate and self-paying that are not submitting to their insurance. So that's something to be aware of, that you might have a patient that has healthcare coverage according to what you have in the system, but they may not be submitting that particular service to their insurance. And so that's something for you to be aware of as well. So if the variance in the good faith estimate is greater than or equal to $400, that's where this dispute resolution process would likely come into play. So there's some settlements and settlement information that has been indicated here. And I've also included some additional information for the consumer side when it comes to the dispute resolution process. But I think it's good awareness for us to know what the consumers are reading and what they're understanding as well. And then there's an independent dispute resolution process that looks a little bit different than the provider-patient resolution process. Again, here's some additional information around that dispute resolution process. There is many, many resources and information out on that No Surprises Act landing page. I think if you have run into these situations or have had some issues with the good faith estimate portion and being able to provide that accurately to patients, you would probably want to dive in a little bit deeper into some of these aspects on the No Surprises Act page, just because this will just provide you with a greater level of information. And again, you might end up having to work with legal to interpret some of these pieces because again, it does get very technical. And like I said, I know that there's some attorneys out there that this is by and large what they do. So it does get into that legal aspect of things. So in kind of wrapping up here with the No Surprises Act and with the presentation in general. So look at where you're at with your journey with compliance with the No Surprises Act and being able to provide good faith estimates. Do you have governance over the application of the No Surprises Act and the communication that's being provided to patients? What are the requirements, the rules and regulations, and the tracking components of federal and state rules? Do we have someone in place at the organization that is taking time to make sure that this is up to date and that we have all the current information? One thing that you can check too is with your compliance officer and your compliance areas. Is this something that's on their work plan to create a checklist, to look at our compliance in the No Surprises Act area, but how about our compliance on the price transparency piece as well? This might be something that your compliance department or your compliance officer might have in place as well. So it's good to see what other individuals at the organization might be looking into some of these compliance components. I know that our first session about a month ago was regarding compliance programming at the organization. This is just another compliance component that oftentimes your compliance team might be tracking and might be looking into on your behalf. So it's a good way to coordinate efforts so that we're not duplicating efforts. It also gives you peace of mind as well. So if we know that this is something that compliance has on the work plan, they're taking a look at these compliance components for price transparency and no surprises, and all looks well. You've got that documented on your work plan. That can give the organization peace of mind. It also gives you that paper trail. So it's always good to have a paper trail when it comes to compliance activities. So with that, we've got about 3 minutes left. Cassidy, I can't see if there's any questions in the chat. I don't know if you can look at that for me.
I'd be happy to. We don't have questions in the chat right now, so since we are at the Q&A portion of the presentation, I encourage you to either unmute right now or drop your questions into the chat. And I'm going to monitor that. And since we have a few minutes left, I'm also going to go ahead and launch our poll and then provide a few links in the chat. So go ahead and drop your questions in, and I'm going to get this started for you guys. And I'm sharing a link to the Rural Engagement Program website, as well as our request for technical assistance, should you want to take a look at either of those. And we appreciate you completing the poll, Rachel. That was an excellent presentation. I don't see any questions right now. If you run out of time with your question or you think of something after the presentation, please don't hesitate to reach out to us. We would be happy to either get the question over to Rachel, or I believe she's provided her contact information on a past webinar, and you saw it earlier. So please reach out to one of us and we'll make sure we get that response back to you. This has been our second of a 3-part compliance series. So we hope that you're able to join us next month. In August, she will also be presenting coding and billing compliance hot topics. And you will receive a follow-up email within about 48 hours with the slides for today's presentation, as well as a link to this recording. There will also be a link to register for that coding and billing compliance hot topic webinar that's coming up in August. So be sure and look for that. Let me go back to the chat, Rachel, and just check. Oh, she dropped her email
I
address.
put my email in yeah. I didn't have it on a slide.
I know you did. I know you did.
That was an oversight.
Thank you, Kimberly, for that comment. She said that it's been wonderful. Okay, so you can go back and rewatch the first one, Kimberly, and I can link that first recording in the email that I send out that follows this session. So I'll make sure you have access to that. That's a great suggestion. Okay, we are right at 1 o'clock, and I don't have any questions in the chat, and I don't see any hands raised. So I think we'll go ahead and adjourn. And we hope to see you again next month. Thank you again, Rachel. It was an excellent presentation.
Thank you, everyone. Have a good afternoon.
Bye, everyone.
I did see a question just pop up at the last second here.
I see that. Do you want me to email that to you, or do you want to address it?
Yes, go ahead and email it to me, and then that way I can respond. But yeah, off the cuff, that the range, they're looking for a set dollar amount. So they're really trying to get away from any kind of an estimate. And so that's why they're pushing for that dollar amount. So that's where the remittance advices have to come into play. So you would analyze the remittance advices and then you would establish your dollar amount based on the remittance advices.
So I hope that answers your question, Crystal. Do you still need me to email that to you, Rachel?
Not unless Crystal does, but I think we're good.
Okay, sounds great. Thank you so much.
Thank you.
Okay, Crystal says thank you. So I think
Okay. Bye, everybody.
Bye, everyone.